What was my biggest surprise was the magnitude of the problem I had to face. There were so many databases in the federal government that summarize the problems that we face in terms of different populations, different drugs, numbers of users, numbers addicted, and also consequences. And seeing it from a national scale was very different than what I had been used to as an academic working in an insular environment. Coming from Harvard, the biggest surprise was the magnitude of the problem on a global scale and a national scale. Well, I had access to federal databases which showed how many people are affected, what ages, what specific populations, the number of drugs we had to be concerned about, and all the consequences. And in an insular environment, in a research lab, in an academic world, you never really take a look at the global impact and the national impact of drugs. I was shocked. I think I had at least 4 accomplishments that I feel proud of. One was to catapult screening, brief intervention, and referral to treatment into a national scale. First, by working very hard with the DREAM team to develop billing codes so that physicians and other healthcare professionals would be able to set aside time to screen populations in various settings and identify people who are engaged in risky or problematic use, or in fact were addicted and required referral to specialty treatment. My second accomplishment that I'm proud of is to convince a number of federal agencies to implement these services in federal programs. It took a lot of effort and a lot of convincing, but we did get a number of branches of the government not only interested but implementing them. The third thing that I was quite happy with is that the Centers for Medicaid and Medicare Services set aside a specific line item budget for their reimbursement. And the fourth thing was to catalyze interest in these services throughout the medical community, throughout healthcare providers, and now I feel that there is a groundswell of support for it that is essentially circumnavigated the US and in other parts of the world as well. We even had a declaration of support by the United Nations, which we garnered. So I think that was a very important thing. The second thing is that I focused on treatment and on drug court treatment, focused constantly on getting individuals involved with these programs to always look at evidence, outcome measures, so that we could be able to convince people to get engaged in these services, because without evidence there is really no substance to programs. Those were some of the things I'm proud of. There are a few others, but not at all. From the president on down, from the head of the United Nations Office on Drugs and Crime, everyone was quite convinced that addiction is a brain disease. I don't think we ever had any controversy about it. We also recognize that personal responsibility is part of the pathway to recovery, but that addiction does lead to changes in the brain, which leads to compulsive use and can result in relapse. Nora and I have known each other for decades, And our lives have been intertwined in multiple ways, including job searches, and not on our part, but job offers, as well as our research base. I've been on scientific advisory committees when she was at Brookhaven National Lab, and tried to explain her research to people who were uninitiated in the field. And we've always discussed the science. We've had wonderful collaborations and collegial scientific discussions, as well as on policy. When I served in the White House, I scheduled dinners with Nora periodically when there were needs that NIDA could help and fulfill. And over a lovely dinner of fish and, and vegetables, I would say, Nora, this is so important for our national initiatives. And Nora, I would always present the data, and she was exceedingly collegial as well as cooperative. When I needed NIDA scientific data for programs or policies, NIDA was there within hours or days to fulfill them. When I asked Nora to set up a NIDA to put SBIRT on the web so that physicians could understand what it is, so that we could have a web-based questionnaire that anyone could use, it was done, and very quickly. We always had this wonderful relationship that continues and survives to this day. There are several good studies that show that the vast majority of physicians that go through medical school do not receive adequate training in addiction. They learn the CAGE questionnaire, which is used to screen for alcoholism. They may have a few lectures or sessions on addiction, but they are not knowledgeable of drug consequences to the brain. They are knowledgeable of nicotine and alcohol, but none of the others. And it does appear that about 30% of all medical school students have adequate education. This, to me, is a travesty, because the medical consequences of substance use are so well documented. They are so robust that not understanding, not learning this, not having the core curriculum address this, to me, is a travesty of medical education. And I certainly think that that has to change in the future, because what we recognize is that so much of medical conditions are related to behavioral health. Procedural codes for SBIRT, as we call it, changed the field because it enabled physicians or physicians' assistants to set aside time to deliver these services beyond the time that is used for regular evaluation and management of patients. So there were billing codes that embraced alcohol and drug screening and smoking, but there was no time set aside in those codes to administer a full screening questionnaire, to administer a brief intervention. The billing codes formalized the process of addressing this problem in all populations. Medications assistance for opioid addiction, for smoking cessation and for alcohol problems has been shown for many years to be effective in alleviating some of the craving and preventing relapse to use. Naltrexone was one of the issues that I thought was very important in terms of helping not only people with alcohol problems, but also with opiate problems. And we know that the statistics show that few people are willing to use what's called an opioid antagonist in treatment for addiction to opioids like heroin. But I certainly felt strongly that this has been underexplored. And so I spoke to industry representatives and suggested that in prisons, I suggested that for some heroin addicts, this kind of naltrexone, which is a depot, could be much more widely accepted and could be more widely used and effective. And I advocated and promoted that and saw that this recommendation actually has come to fruition. I think there are probably three challenges. One is that we need billing codes that are going to reimburse at the level at which people evaluate diabetes. Secondly, we need far better medical education to alert physicians on the essential need of evaluating for this, because, as I said, so many medical conditions, exacerbation of diabetes, depression, sleep problems, strokes, cardiovascular events. There are so many medical conditions that are associated with substance use, but that is not emphasized or a core component of the curriculum. The third thing is that physicians have to learn not only the medical association, but what to counsel people in terms of why there are consequences in their lives that could be alleviated or diminished by reducing or eliminating substance intake.